So here's an idea. Since John presumably knows all the Cerner folks, why don't we start at just one or two sentences, because otherwise we'll run out of time. One or two sentences of intro from everybody, so we get to know each other just at the most superficial possible level. So why don't we start with the Cerner folks, in case John's coming on, he already knows you guys. How's that?
Sounds like a plan. Why don't I start? My name is Hans Buitendijk. I'm a director of interoperability strategy and involved with a variety of different interoperability focused industry initiatives. So that's me.
Great.
Clayton, you want to...
Yep, I can hop in. Clayton Anderson, Senior Product Manager over Clinical Privacy. So I work with a lot of our Millennium-based and clinical applications around making sure we have appropriate data access for those individuals that are permitted to see it.
Great.
Dan?
Yeah, hi, this is Dan Levine. I'm a director for behavioral health. So I work on behavioral health software with an emphasis on privacy especially for substance use data.
Josh?
Yes, Josh Mast. I am on the regulatory strategy team. So I'm actually on the same team as John. So when he joins, he would be given a similar background, although John has been here much longer than I have and involved in more of this at the industry level. My focus on the regulatory side is largely on interop and information blocking and a lot of those requirements.
All right, so I think we've got your team handled. So why don't we start with Daniel? You want to take the ball and start us, and we'll go through our team.
I think just very quickly, I'm Daniel, one of the co-founders of Stewards of Change, and thankful for your time to help us better understand what you guys provide in this area, so we can integrate it into the scan that we're doing for Robert Wood Johnson Foundation. I think I'm losing my voice, so I'm going to be a little quiet.
Okay. Jung, you want to say hi?
Sure. This is Jung Kim. I'm a principal consultant with Gainwell Technologies, currently focusing on health and human services, and in it, data analytics, data governance, data sharing, and all other things that are related.
Great. Michelle?
I'm a clinical analyst with Zane Networks out of DC. I work primarily in behavioral health and substance use disorder, helping to ensure that the data is shared appropriately and within regulation.
Jim? Brian, jump right in.
Sure, I'm Brian Hanspicker. I'm CTO for Open City Labs. I'm also the technical project lead for Project Unify, co-chair of the consent governance and technology working groups. I'm on various and sundry standards bodies like the Gravity Project, TAC, and etc.
Amanda, say hi.
Hi, everyone. Amanda, Stewards of Change consultant, work closely with Daniel and Adam and the Project Unify team.
And Jim, can you hear us? All right, Jim will come in when he can. And I'm Adam Pertman, and I work.
Trouble operating my mute button, Adam. My apologies. Chief Trust Officer for Lemetic. We work on digital identity and consent. Very pleased to be here with Unify. And Hans, I think you and I were involved in IHE International together at some point too, unless I'm mistaken. But I think that was I think yours is a familiar name as well. So.
I've been dabbling in the IHE here and there.
I'm Adam Pertman. I work closely with Daniel, who heads the organization, on a variety of our projects, including Project Unify, and I'm heading our consent scan project, which is a part of Project Unify. And just very broadly, everybody, Cerner folks, everybody you see here who is not one of you, is working in some capacity on Unify and the consent project with us. With that, I'm going to go off, stop video, and go to, because I'll be taking notes from the excuse me, the file I set up to do this interview. So I will lead the interview for us, but I want to strongly urge the people who are with us, because you are all subject matter experts to a degree I am certainly not, to please jump in anytime with your own questions, observations, etc., especially questions if you see something in your area of expertise that you think needs to be addressed, okay? All right, so you all, Cerner folks, you, Hans et al., you got the group of questions that Amanda sent you? Yes?
I did receive some questions that's accurate. I
Okay.
did not have, based on timing, a chance to
Yeah, that's fine.
dive deeper.
I'm going to read them aloud in any case, so that's okay. And take these are sort of, not sort of, these are meant to be apples to apples for all the interviews that we do, so that the questions are consistent throughout. But obviously, feel free to adapt the question and say that for our work, the question is really X. You know, adapt the question and the answer so that it is appropriate for you, okay? So first, in the report that we're going to write, we're going to describe each of the initiatives, we're calling them. I'm not sure what we're ultimately calling them. Cerner is something more than an initiative. But what key or core information about the work you're doing in the consent area should be in our consent scan report? In other words, what do people know about, should they know about, people read the report, know about Cerner and its work in the area of consent that is instructive, enlightening, important? And any of you can take it, obviously.
Lady, you want me to give a first crack at that?
Yeah, why don't you go and I can sprinkle in some additional context.
So I want to react a little bit with which actually you already started with, and then that Cerner is not necessarily an initiative.
Right.
So it is a provider of HIT, EHRs, pop health, lab systems, etc.
Sure.
Cycle, you name it. So I think the role of us in consent is helping advance and manage the ability for patients to record what can or cannot be shared, enable users to help manage that then accordingly so that they share it appropriately with others that they may or may not be able to do. Work with our user community, provider community, that where they may have to document that works, and where policies are available at national or a local level that further inform. Dan Levine would be able to get more into 42 CFR Part 2, whether it's HIPAA, whether it's other rules, to help establish that. So I think it's more that we are a provider of the capability as that emerges and evolves to help enable that, to streamline that, to make that better from where we are today. But there's still a long way to go. But
and how does consent come into that?
Consent comes into that because that's where there is the requirement that certain data can or cannot be shared. So I'll let Clayton and Dan dive deeper into what, where, and what we currently are able to do. And we can also talk about where some of the challenges are to further enhance HIT to support that beyond a patient or otherwise being documented says that you cannot share it on a piece of paper, and then a user needs to determine what data they can share. So that's where I'm going to stop for a moment and see whether Clayton and Dan can drill a little bit deeper in the respective areas of where we are at.
And again, if you could think about Clayton and Dan about, you know, what is enlightening for people who read our report and see, oh, they're Cerner, they're big, they do a lot of work in this area, you know, sort of what are some key things they could actually learn and not just understand your process?
Yeah, I'm actually going to take it up a little bit more and then we'll dive back
Yeah,
down.
great. Great.
Hans referenced that we really are around capabilities to do things. And when it comes to consent, it's a bit overloaded, just the term consent. At its core, all consent really is a permission to do something related to some entity, whether that's a person or an organization or anything like that. And so when we talk consents, our first question is usually, well, which consent are you talking about, right? Is it consent to treat? Is it consent to share data? Is it research studies? Is it, last year, now can I record this telehealth visit? That became a new one that we had to start accounting for quite a bit more. I think we're gonna narrow it down a little bit more into sharing data. And with that, we have to be able to provide technical capabilities to share data with the patient themselves, with their next of kin, their guardians, parents. We have to, there's what, we're seeing now in some of our global spaces, so we can get into some of the challenges and nuances later, is a consent to share it with another clinician, right? We struggle with interoperability a little more in the United States than they do in some of these other more national or social healthcare markets.
Yeah.
But over there, the interoperability isn't as big of a challenge, but access appropriate interoperability is a little more of a consideration. So does that clinician, and Dan definitely deals with this in the behavioral health space, does this clinician have permission to access certain types of data, sensitive often? Information exchanges, the other two areas that have become pretty big lately, public health entities. So when we're reporting things of that nature, how do we capture those consents and transmit those consents? And then a little less on the clinical side and a little more on the business side as your big data companies, right? We know Google is now in play. They want as much health data as they can, Amazon, the Apples of the world. And while they're probably doing some research, they're also probably using it for some marketing purposes. And so how does consent weigh in there? And are those different consents, even though the recipient is the same entity? So for us, when it comes to sharing data, it's really about capturing that consent. Ideally, we're capturing it in a way that the person providing consent understands what they're agreeing to. And then technically, how do we enforce and transmit that consent? Because with consent, it's, like I said, it's a transaction. There's a sender and a receiver. That receiver is often not the only receiver. There could be secondary, tertiary receivers after that you would need to be able to transmit that consent along with. So that was a little bit. I can let Dan touch on the specifics around BH.
And I have a quick question for you. So you kind of went through an inventory of all the types of consent you address, and thank you. We run into that a lot in our discussions with other interviews, as well as our internal discussions, is, okay, what kind of consent are we talking about here? Do you branch into the social determinants of health and sharing consent with non-HIPAA covered entities, clinical data with non-HIPAA covered entities at all? Or is that?
We have technical capabilities that are fairly flexible. So a lot of times this is going to come down to an organization themselves and their business associates agreement with another entity. Our role in that would be facilitating the capture of that, not necessarily the agreement between one organization and a third party.
So you feel you have the technical capability to share data across multiple domains, realms, systems, whatever it is. It's not a question of technical capability. It's a question of whether the various parties want the information and have agreements with each other to get the information. Is
right.
that fair?
Yeah. The interoperability has been a interoperability of data has been a big focus for us in the past 10 years, and Hans and Josh can speak way more to that than I can. But the enforcement of just, yes, is this field in place, or is this piece of data stored, that when you were to engage an enforcement engine or enforcement logic, it can check against that attribute.
So quick follow-up, do you find there is, how much sharing of information are you finding across health and social services? You alluded to this before. In the US, not so much, right? And but in other countries more. What are you finding? Is there a trend line here that it's happening more? People talk about sharing to achieve to use the social determinants, but is that happening in your vision?
I'll defer the US piece to Hans, but I can speak to some of the global arrangements that I've been involved in. They've often stood up a national HIE, for a better word, whether that's in your Nordic companies or something like the NHS in the UK. And when it comes down, as long as they're able to store that data, receive that data, and store that data, we would then look to be able to facilitate that transfer.
And the conversation is honing in a little bit more specifically of social determinants of health, not consent in general. But two comments there, and I see that John Travis joined as well. But the part there is that the level of granularity at which consent can be documented today, and that it is workable so that it can automate more and streamline the process of actual sharing, is where there's still a number of challenges, whether it's SDOH or whether it's clinical data. Otherwise, that is really where the challenge lies at the moment. So that is part of overall something that the industry and us participating in that to make that more manageable. So right now, you'll see that being able to share or not share based on behavioral health, that Dan Levine can talk a little bit more about. There are certain approaches to do that, but it's still at a fairly coarse level, not as granular as there is a desire to do. If we then specifically within that look at SDOH, if I hear your question correctly, sharing of data between providers and other data sources, there are abilities to share based on the relationships that have to be established, that such data can be done into analytical pop health type of environments. But the question there is the biggest question right now there in general is that what HDOH data needs to be shared with EHR specifically, where into the workflow, et cetera, where not, where do we need to have, what kind of agreements or consent needs to be in place. So there's still a fair amount of work to be done to really understand what's happening. So we are really at the starting point of that. And that's why you hear us more talk about, we are enablers as that becomes clear what needs to be shared, what can be shared or not, and how that's managed. We're enablers of that. So in that sense, it's hard to answer your first question that you started out with, if that helps clarify.
Yeah, that's great. Anybody else before I move on?
I just had a question for Hans. So, one of the things we're seeing is that there are various regulatory challenges, disparate regulatory models around consent that I think, when they are addressed from an EHR-centric perspective, enable users to be able to do that, especially as it gets more granular, irregardless of what the regulatory environment is. Just kind of with regards to like the standards and I guess the SDOH, I know Cerner contributes across the board in a lot of HL7 initiatives. Are you looking at things like Gravity Project and US CDI elements? Is it a matter of standards or consortia work outside of HL7? What do you see as some of the guiding standards development forces there, if I could ask?
I believe that we need to look at this, that what is done in SDOH and what is done in general, where there's a lot of similarities. Clearly, we have participation. The initial outreach was to Hannah because he's involved in gravity and has relationships there. So engage in that clearly with you as core. Other ones, that's the data itself. There is the concept there of data segmentation, DS4P, security labeling, etc. And there are outside of HL7, there are efforts going on, PP2PI, etc. The LEAP project that occurred. If we look at that as more general consent, how do we manage that? It's all looking at the chain of how do I capture in a computable fashion patient consent? How do I capture in a computable fashion policies that stand at a local, state, national level, whether it's along the lines of HIPAA or 42 CFR Part 2 or other privacy policies. And then we need to apply that to the data. Now, if you look at the standards that are out there, you're starting to see is that initially you needed to start to mark documents as sensitive, and then that's starting to trickle down into the more of the detailed level. That entire process, that all those components fit together, and therefore that we can understand what data is supposed to be managed how, according to the patient, according to the policies, and how that has been documented. That's really where there's still a lot of work to be done to make it all fit together. So initiatives that are in play there is where we're very interested in participating, contributing, understanding, so that we can help move it forward. Because right now there is still a lot of manual. If you would like to share information between one organization and another, there are parts that could be done based on certain qualifications, like in behavioral health, and therefore you see a lot of time that data is not being shared because it's otherwise the level of granularity is not enough to really manage that. So it's limited sharing. That's where we're looking at. To help move that forward. So that's where we really sit, is that we are trying to figure out what are the right capabilities and how can we enable that it's easy for the patient, easy for the provider, easy for the policymakers, and consistent, that we can bring it together and streamline that. Because right now there's a lot of manual effort, selection, otherwise that's needed to ensure the right data is being shared, and not too much, not too little. And
at the provider level, there's still a lot of reluctance to participate in sharing, because the patchwork of regulation that applies at every locality is so different. And it always involves anyone who wants to take on that initiative at the provider level really has to get their own lawyers involved to say, hey, can we do this or not? Is it allowed where we're at? And that patchwork is incredibly difficult. And then you layer that on top of that, you layer on the history. We really started to delve into privacy in probably the last place we should have started, and that was with substance use treatment. Not because it doesn't deserve the most attention, but because by its nature, it has the most private constraints around it, and it has constraints that are fuzzy, and that is that context matters. So you can't reveal that someone is in substance use treatment in any way. And if the only thing you're calling sensitive is substance use treatment, just by flagging it, you've now indicated that this person is in substance use treatment. So even when we began this, we had a problem with the ability to use that policy determination, or that determination that, hey, there's a policy that's coming into force here, but we're not going to name it as 42 CFR because that gives away why the policy is being applied to the person. And that's just touching the iceberg on where that challenge is. But until we have some regulatory unification from all levels, and it could start at the feds with 42 CFR, but a lot of states have inherited the same kind of language and policy for other parts of mental and behavioral health use that you have to watch and be careful at the state level as well. And without that unification, it's just really hard to get the consent to translate across. It's expensive. Even folks like Cerner, who, we have probably one of the largest test cases with our Veterans Administration rollout and having to deal with consent there. Even there, to bite this all off and say, hey, we want to do this and we're going to create the model and we hope that people will jump on board. There's just, it's just too massive for any one company to take that on. So it has languished for the 12 years I've been involved with it.
That actually was real quick, my last follow, and then I'll shut up. But that was my next question, because the VA gives you the 38 USC 7332 use case, and I know that was a preliminary effort with SAMHSA. That was some of what got incorporated with DS4P. And I was just curious, and I think you kind of addressed it, Dan, whether or not Cerner was looking at it at Madigan and the like as kind of a discrete use case around both the regulations and the architecture.
Yeah, I mean, I think even if we could envision a perfect way to deal with this, we can't do it as Cerner or even with just the VA. So anything we come up with, we would want to set expectations about how Cerner is going to handle it with the VA. It's just always kludgy. I think at this point you try to glue it together, and there it's a use case specific thing as well. With the VA, it would be kind of specific to how things have to go with 42 and 38 for the VA. Because you got the 42, you can have community behavioral health clinics receiving information coming out of the VA. Now you got both 38 and 42 involved, because both sides have to make sure that they're dealing with that correctly. And then you've got to reconcile those two laws, and they weren't conceived of together, and that's just federal. So, and on and on and on, right?
Yeah, appreciate that.
That's great. Anybody else from our side? Any further questions on this sort of what is Cerner and how is it dealing with consent? Okay.
I just had one very,
yeah.
very simple question. I know we've talked about 42 CFR and HIPAA. Have you dealt at all with any of the educational consents on FERPA in terms of bringing like records or, attendance records or assessment records into an EHR? Is that part of your, anything you guys heard of?
I have not.
Okay.
Nothing I'm aware of.
Okay.
Okay.
Back to you, Adam.
Nope. Okay. Yep. So again, keeping in mind that we're focusing. I mean, we do a lot of work on interoperability and information sharing of various sorts, but keeping in mind that this is mainly focused on consent. Can you talk a little bit about what the main purposes are of the consent work that you're doing right now? What are the problems you're encountering? How are you working to address them? And the examples we give in the question we sent you is, with care coordination, is it all for one-way referrals, or is closed loop referrals? Is it just for providers and their patients? Talk a little about what are you mainly trying to achieve with your consent efforts, and what are the issues that or obstacles that you're finding?
I can at least start on this one. As I do a lot of our product development, and I'll be honest, it's not the ideal answer, but a lot of our consent development from a product standpoint is tied to what we have to do for certain markets regulatory requirements. It's a little of the tail wagging the dog, unfortunately, but you have to have certified EHRs, right? You have to, in order for us to be in the market, we have to be regulatory compliant. So when regulations get passed, Josh and I here on the phone, we spend a lot of time with each other as far as figuring out what that means, whether that's US based regulations or global regulations. In a perfect world, these would all align and everybody would be using the same standards, but they don't. You can have some people that or some regulations that are aligning to fire and HL7, and that's what we would prefer, because that is a good way for us to make sure that we're playing ball with everybody else that's going to need these consents. It just doesn't work that way, unfortunately. I think what we saw a lot last year, specific around COVID and those vaccinations, what we did there was kind of an agile, move fast type capability, is re-leveraging some of those more simple yes, no, form-based consents, right? And so as long as you can capture it in a discrete field, and we can, put a script together that transmits that discrete field from, one immunization registry in one state to an immunization registry in another state. Sometimes it's not the sexiest way of doing it, but it works, it's quick, and it's something that a lot of our clients are already familiar with this capability. All they have to do is, an hour's worth of configuration and then, run some tests to make sure that, yes, that transaction is being sent. So I don't know if anybody else wanted to hop in from the Cerner side.
Well, I wanted to jump in a little bit on the what kind of problems, challenges do we have, and that's going to be not specific to whether it's in care coordination, one-way referrals, or otherwise, the kind of use cases where data sharing occurs. It's much more the general notions that the capture of policies, be they patient defined on what they want to share or not with whom, or from policies as in legislative and otherwise, capturing that in a consistent computable format is one of the challenging areas. Is there enough alignment there? Yes, I have with a SAMHSA consent to share, or you have with the ONC Elite project, you have capabilities and others as well on how to capture consent. But do we truly have, at least consistently across the United States, the vocabulary, the encoding, that it would be clear what the meaning of a particular statement is across those? Then the second part is that ensuring that data at the right levels is then being flagged using appropriate code so that you can evaluate that. And is there agreement on what that means on how you send data in and out, etc. But making sure that the tagging of that data can be done with the least amount of user input. And until we understand that and can work with that, it is very hard to, outside of human interaction, to actually include or exclude appropriately certain data. So I think if we're looking at challenges, main purpose, yes, we are on the same page there. But if we talk about the problems that we're running into, the challenges we're running into, it's that type of discussion to actually make it work beyond just an electronic documentation of text into electronic documentation of encoded policies that we can evaluate with appropriate tagging and appropriate policy rules around it that are unambiguously understood, no matter what jurisdiction you're in, and no matter what jurisdiction the data might end up in, based on the sharing data across the state or the country. So that's where the area of the hard nut to crack is. That really is our biggest concern.
Yeah, that's certainly a giant one. So how are you addressing that? What approach that's not proprietary can you share with us that is helping you crack that nut, or at least address how to proceed with it?
Participation in the variety of initiatives to help move this forward. Because if we do something on our own, then that does not mean anything whether somebody else can deal with it, because the data goes elsewhere or we get data from others. So it has to work together to define that infrastructure. So it is HL7 participating there. It's PPE to PI. It is in other countries. That's where we participate and contribute to help move this forward. But it's not a fast process because of the complexity of this all. But then, do you want to share in the meantime some of the things that we have done in behavioral health on how we could share data that with CCDA documents and otherwise, that there are opportunities, but they work in individual instances, but scaling it nationally so that that works and consistently, that's where the challenge lies. So you could make things work in an individual interaction, if you will, or a small scale. But going beyond that is where you then quickly run into, I need to agree with many more parties to make that work.
Right. Yeah. The best example that we have where we had to do some customization, but we tried to stay as close as we could to standards in order to push the envelope on this, was a project between Cerner Behavioral Health, the state of Iowa Department of Corrections, and substance use provider named Irely Ball. And the solution that was arranged there was basically you would have prisoners coming into the Department of Corrections systems at all hours of the day, and they wanted to know if they had substance use treatment backgrounds and anything they needed to be dealing with as they came into Department of Corrections. And this independent community center, Irely Ball, was a place where that often happened. And they wanted an automatic way to query them and say, hey, do you have anything there for this person? Now, what that requires under 42 CFR is we have to have permission from the patient, the inmate in this case, to get the records from Irely Ball, and we have to transmit that consent to Irely Ball if it's not already on record, and we have to be able to parse it in an automated fashion. We have to determine if it's accurate and complete, and then we can release it. It's what I call the self-addressed stamped envelope model. We are sending a document across in the first place that says, hey, Joe is here with me. Joe has told me he's had treatment at your place, so I already know that from him. The document I'm sending is his consent for you to release to me. I've done all the paperwork for you. Here's this self-addressed stamped envelope. If you can just review that, rubber stamp it, and send us the data back, we'd love it. We'd be pleased. And that works in this process. And a lot of the pieces are in place. There's a basic consent mechanism over a CDA document that we were able to leverage, but we had to extend it with a few items. We had to leverage direct messaging in a way that it didn't quite have to be able to see these messages coming in and recognize them as requests for consent. So you have to have a mechanism in the transport layer that shows that piece out. And this is just kind of one small scenario where you take this ability and we're working around the idea of disclosing someone's in service before you have permission to know that they're in service for substance use treatment. And it works quite well. It's been a few years since I've been involved with that. I think it's still in use there. But it took, I was on the phone with lawyers for several months working out the details of how this was going to look. And that's kind of what it takes every time we do something like this. If we could start to codify these general things, identify, as Hans said, the places where the normalization and standardization of data hasn't quite reached maturity yet, then I think we can get there. If we look at interoperability as being, say, in its late teenage years of maturity, I think we still see lots of room for that to mature into adulthood, but it's at least an older teenager. If we look at the consent side of things, we're looking at, I'd say we're out of the toddler stage, but we're still not over 10 years old in terms of the maturity age of being able to do the consent. We're a good 10 years of human development behind in terms of making that work together. And that just creates this firewall. Whenever consent is not just standard and vanilla, then there's this firewall between getting that information around, and everybody kind of gets scared to either take on the challenge of it or the legality of it.
Real quick, Dan, Irely is I assume Ball is spelled B-A-L-L. I don't know that, but Irely.
Yes. Eyerly. I will look that up to make sure.
Okay, and I can Google it if I'm close, but I think I wasn't even close.
If
yeah, go on.
With your Department of Corrections project, were you able to do anything bi-directional? So when you had that established that consent in the beginning with the patient to receive the data into the correctional facility, were you able then to extended as when that person became a returning citizen, the data could go back to that substance use disorder facility?
Yes, I mean, I don't know, for instance, for sure that they used it in that way, but it certainly could have, because once we have established the consent, since we did this over direct messaging as the transport layer using CDA documents, once the documents had been exchanged with the consent, then they were free to exchange anything they wanted by direct mail, and could continue to do so. So yeah, on discharge, they could do the same thing. And part of what we all comply to regulatory for standards for meaningful use and things that have come since is the ability to send a CDA as an attachment to a direct message. So again, we were leveraging that ability. The only rough thing there is the only form we have available is the CDA. We're shoehorning everything into that when you're using direct messaging. That's not getting into the realm of more granularity that we can get with fire and some of those more dynamic things, but it at least takes the old fax paper paradigm and puts it into something that doesn't involve printing out paper and walking it down the hall.
Yeah.
I was
Baby
actually gonna
steps.
ask you
Baby
about
steps.
that. Michelle, did you have something more?
Yep, that was the answer to the question. I was just curious if you were able to work it bidirectionally.
Yep. Cool. Anybody else on this question and from our side or either side? Okay, I'm going to go just to a piece of the next question, which because we can categorize how Cerner fits into the big picture. But what is it about Cerner's work, particularly about consent? This is just a hair self-serving for you, but go for it. What makes Cerner a good model, a good place for us to choose to highlight the work you do to make it worthwhile for others to look at? What elevates Cerner's work in your own minds that makes it worthwhile to examine?
I'll start here. I would say that our global footprint has allowed us to see a variety of consent that I never would have thought possible. And I do think that there's going to always be somebody at the bleeding edge, and then the bulk of the market's going to catch up. I think we're seeing some of that bleeding edge. We've been introduced to it, and we know that consent is going very much away from black and white to black, white, and 50 shades of gray and in between. We've already been introduced to that. We're planning on it. We're developing against that. So when certain markets do start catching up, when it becomes the norm, we'll be well positioned to be able to account for what I like to say is, sure, you have my consent to share this data except for, or it's not just a single consent anymore. It's a consent except for, or it's a consent except for this person, but not for that person. So you start getting different levels of granularity, not just on the data, but also on the recipient. And we're being exposed to that already.
So I'm assuming
revokes anything.
Say it again.
So that's before anybody even revokes anything.
Right. Exactly. Yeah.
So that's interesting. So when you talk about you've seen the bleeding edge, I assume that you're not talking about project X in state or country Y. How would you define what are you seeing when you see the bleeding edge?
Models of data sharing is what I would say, and the granularity of how granular we're being asked to be able to share data or not share data, both on the data side, so down to individual pieces of data. Once again, they still got to have some type of codification standard behind it. We're not to the point of amazing NLP and free text capabilities yet, but the data side and the recipient side. So what happens? We've generally thought of these as consumer provider system. right? Like as your generic recipients of data. But what happens when you start getting into additional pieces of consumer? So you have your primary consumer, maybe the patient themselves, secondary consumer, legal guardian, somebody with some formality of access to data, next of kin, something like that. And then you start getting into, we talked about SDOH, school nurse, soccer coach,
Yep.
how much access do they need, and things like that. And, you can see it on your devices now, air quality index, right? Like that's not something that, we would have factored into the medical record 10 years ago, but now we do know the soccer coach probably needs to be aware of the kids on his team with asthma when the air quality index is very poor today. So should they have access to that granular level of data or not?
So the
That's not for me
bleeding
to make
edge,
policy, but
I'm sorry. So the
Not-
bleeding edge is what I hear is the granularity and the ability to deliver on granularity at every level, at each stage, at every level.
right. And to Hans's point, we're nowhere near that from an industry standpoint. We have been exposed to the need for it, but it's not something that Cerner alone can do. Right? We got to come together, hand in hand with everybody else in this industry and say, yes, this is where we need to go. But in order to do that, where we're not just all stepping on each other's toes or creating conflicting policies, we got to have the standards in place to get there.
And there's another that's on the data content and the rules clearly. Then you have the infrastructure. That is, I'm not sure whether it's a bleeding edge or it's just bleeding. In that you have a model that can say, I'm going to go full patient mediated. Who can you share with? Which then means is that there's models out there that and actually being worked on. So this is not just theoretical, where the data is a patient's data is kept in one place. And it cannot move from one provider to the next unless the patient has given permission for certain of the data. Now, within that, then you get the same question of how granular are you organizing it? There's in that space, there's feedback and requirements. Well, it's too coarse, needs to be more granular or whatever. So that remains static. But how do you do that in that kind of an infrastructure where literally it's fully patient mediated before it can be shared? Then you have other approaches that says, well, I have my patient directives. They might be present in multiple places because I declared certain consents with provider 1, with provider 5, with some other place. But for somehow I need to get access to that information to properly manage it. How are you going to do that? Are you going to send it along? So there's infrastructural type of challenges that different models are being explored, see what can work, what doesn't work. How do you deal with it if the patient is cannot provide the consent because they come into the emergency department? So it is infrastructure and granularity questions that are both require substantial amount of work to figure out how to do this.
And Hans,
For computers.
that feeds into what I was going to ask Clayton, which is that some of the European consortia that I participate in from a GDPR perspective are looking to personal data stores and enterprise data vaults in lieu of obviously like an EHR centric record model. And it sounds like you're encountering that through, like My Data Global and some of these other groups that are advocating that sort of thing. So.
And anything in between. So is it a one singular place in the country, or are there multiple HIEs that in the US context are looking at it or trying to figure this out? And then you have the provider specific source. So what between that is the right place, and how in each of those models and which one actually works, can we help maintain a singular understanding of what's happening? How do you make sure is that that in the process of that you don't divulge accidentally by implication where the patient has been that they didn't want you to know about? So how do you manage that? So there's a couple of different ways to go about that. Some are more complex in one way if I need to do it in a federated approach. How do I do that? Is the role of the an HIE in lowercase, if you will, not necessarily an HIE, but how do you use that? What's the right level of abstraction to do that? Or do you need to go all the way up to one singular point for the patient, or something in between that's worked on in another place? Is that with thoughts around if you've heard of Solid Pod, what they're doing in the UK? Perhaps that's something that's going on that it could be multiple places, but it's not tied to necessarily a provider. So those are the infrastructure models, and then you have the data granularity models, and then you have the provider or the party that does the documentation, where everything needs to be flagged appropriately with the least amount of effort and the least amount of flagging. So those are the 3-4 major pieces that I think it's a big juggle right now to figure out what comes first, and if you don't have the other one, can I move forward?
Right. It seems to me as a non-technology person that this would be literally impossible without the advances we've made in computers and more, maybe more specifically, I'm guessing, with machine learning and the like. Because how would we possibly get down to the levels we need to get to?
Machine learning will be an interesting one. Is that, can that be precise enough for the level of privacy that you are trying to achieve?
Yeah, yeah. Okay. Again, I'm going to ask: do we have a hard stop at 3, folks?
I do.
I think we do. I think we do. So, and I want to be respectful of your time. If we miss anything that we think is critical, we'll get back to you and maybe send you a couple questions in via email and ask for responses, if that's okay. So with just a few minutes left, I want to give it to the rest of my group. Anybody else have a question or an observation before we wrap this up? Because we only have a few minutes. Otherwise, I will ask one more question.
I don't know, Adam, if we covered the community-based organizations and the exchange of information and how Cerner thinks about that earlier. I can't recall if that was in this call or not. And is that a relevant conversation to have?
Well, we haven't asked, so
okay.
Pose it as a question.
Yeah. So with the Unite Us or Aunt Bertha's or Now Pals, they're collecting a lot of social information at the local level. Are you finding yourselves at all needing to exchange information with them or receive information from the social? And how, if so, how do you deal with it? If they have a consent process, how does that interact with Cerner's, if it does at all?
I'll be honest, I'm not terribly familiar with those organizations, so that might actually be more of a Hannah question. I know she was deferring some of those the consent questions to us, but she might have more familiarity with those organizations.
So more broadly, are you finding a need to go outside of your client base? You know, the hospitals or EHRs, whatever. Are you needing to, because you're dealing with social determinants, are you finding you are broadening your efforts to work with organizations outside of healthcare?
This is
Go ahead,
Josh.
Josh.
I think that probably depends on what our clients want. We're gonna look to bring in the data that they want to bring in, and if they're looking to bring in social determinants data from different groups or to send social determinants data to different groups, community providers or otherwise, then that's really their decision, and we try not to get in between the clients and who they're choosing to interact with that data, bringing in data or sending out data. So I don't know that that's necessarily something that we get involved in at that level.
Yeah.
And maybe to add to that is that that might start as individual providers that have an interest, but as they become more wider needs that are that cut across providers, then I think you will see us back in those industry initiatives where the work then goes on, how can we do this now in a consistent standard way, that when there's a connection, what do I do? Whether we necessarily always will go out to those other parties directly, I think that's where Josh clarifies. But once it starts to become more of a general need and starts to pick up on that, that's where we are looking primarily then at collaboration across the industry to see how we can do that in a consistent fashion, so that interacting with organization 1 or 5 or 10 across different states, that we're not going to have to do it in many different ways.
Right.
Because that just makes it more difficult for us to support all our clients. The more that we can help align on that, more standards based. Maybe one needs more data than another, or is interested in more or less, but where the data is the same, let's exchange it and access it and share it in the same consistent fashion.
Josh, do you see a significant request or do you feel like there's a trend in any way of providers that you work with, different hospital systems, et cetera, wanting to share that substance use or the SDOH type, wanting to share data with community-based organizations, et cetera?
I don't know that I've heard a lot specifically, but I think the HIPAA proposed rule that kind of came out around the change in administration specifically called out community-based organizations, right, and providers, and them being looped into TPO. I don't know that that was necessarily a change from what's already in HIPAA. It seems like it was more of a clarification in that these are acceptable providers to send to under TPO. I have not heard much chatter on that specifically, but I imagine that, assuming that gets finalized, I don't know why it wouldn't. Assuming that gets finalized, plus the information blocking. I think information blocking to me has been the larger conversation, because that has required everyone to just relook at and refocus on all of these policies that may have been in place for years without much going back and reevaluating. So going back and looking at those with information blocking in mind, and just making sure that that they're still applicable and that they're still at the level that you want them to be. I've heard a lot more on that side, not necessarily with community health providers specifically.
Okay. With that, I think.
And I would.
Oh, go on.
I'll just throw one quick comment in too. There's been a focus on SDOH here, but I think more fundamentally for our clients, providers on the ground, which my focus is on the community behavioral health clinics, but being a part of Cerner, of course, Cerner's mission long before my little group was around was, of course, hospitals. And now the big issue isn't so much about being able to mine the data and figure out where we can predict these things are going on, but it's more practical. It's on the ground. How do we coordinate care between community behavioral health clinics and hospitals, and stop thinking about acute and non-acute? We now talk about the continuum of care, and if the continuum starts with community clinics providing outreach and help to folks in the first place, we have a lot less people that make it to the ER because they're having any kind of behavioral health episodes that lead them to either physical or mental health issues. So it's way more practical about just communicating data between these entities and the consent piece that plays in it to there. If we focused on that for the next 5 and 10 years, we'd make a huge impact as well.
Adam, that raises one quick question. Dan, Dan's still there. One of our premises for this work is that if we can figure out consent and some kind of ubiquitous consent across the major required areas, that might really advance the work in a significant way across the country. Right, so if everybody didn't have to figure it out and everybody didn't have to handle all the disparate approaches, we would be able to theoretically, the industry would be able to do care coordination much more effectively. And our proposition is that is a seminal fundamental innovation that if that could be made to happen would actually make change at a scale and a structural level. Would you agree with that? Would you?
I would agree, and we have to solve the hard cases of consent.
Right.
Not necessarily like we were talking about granularity, but if we've tackled easy things and then we've left the hard things languish.
Yeah.
42 CFR is something we've been trying to use as a harder case, but it keeps being thrown out as an outlier, and it's probably increasingly. I mean, that thing is evolving quickly as well. It's been sitting still now for several months, but there's been a lot of movement on what 42 CFR even means these days and the evolution of where that's going. Is it a barrier? Is it a help to those who are receiving substance use treatment? But yeah, we across the board, if we could bring a lot of big pieces together, and it's no small task. So I mean, I'm glad there's a focus being put on it. But you're right. I think consent is a very important lever that could move the needle in a much larger, amplified way.
Thank you, Adam. I think we're.
Yeah, that's great. All right. Thank you all immensely for your time, for your insights. Really good stuff. We very much appreciate it. And as I say, if we, as we're plodding along, and this is going to happen within a month, we'll get to completion. As we do, if we think we're missing a piece, we will certainly get back to you. Okay.
Yeah.
All right. Thank you all immensely. Have a very good evening.
Thank you.
Thanks
You
for
too.
reaching out.
Bye-bye.
Bye-bye.